Welcome. My name is Michelle Lane. I am the Senior Director for Community Health and Wellness here at North Kansas City Hospital, Meritas Health. And do I have a treat for you guys today? We have got Stephanie Ramirez, and she has been practicing speech and language pathology since 2009, primarily focusing on outpatient rehabilitation with adults. But in February of 2021, Stephanie founded the Virtual Brain Injury Support Group through North Kansas City Hospital and has been an absolute favorite for our fan club members. She has been a guest speaker at the KU Concussion Symposium, the STEM Saturdays at Union Station, Brain Injury Association of Kansas, as well as the Kansas Speech and Hearing Association. She is a certified brain injury specialist and has her certification for oncology rehabilitation through the Physiological Oncology Rehabilitation Institute. Stephanie enjoys spending time with her husband and her two yummy children, Owen and Mia, and rooting on her alma mater, the Oregon Ducks. So please help me welcome Stephanie Ramirez. She's going to share with us today head and neck cancer, understanding the role of swallowing, speech therapy, and survivorship.
Thanks, Michelle, and thank you everybody for tuning in, whether you're with us live here or watching this as a recording. I'm so excited to share this information. I think it is so important, and knowledge is power. So the more we can understand and know, the better off we will be. So, and it's very timely because April is Head and Neck Cancer Awareness Month. So I'm very excited to share this information. And hopefully you'll leave today with a little better understanding about head and neck cancer and the role of the speech language pathologist. So for today, I'm going to start by just reviewing some dysphagia basics, kind of describing what it is and what we look for. Then we're going to get into head and neck cancer, talking about diagnosis, evaluation, and treatment. And then finally finishing off on survivorship and kind of looking forward at what the horizon holds for treatment options. So first of all, dysphagia is the medical term for difficulty swallowing. So swallowing is actually one of the most complicated things our body does, and we do it hundreds of times, about 500 to 900 times per day, actually. And it is a coordinated movement of the muscles in the mouth, the throat, the esophagus, and it transports food and liquid from the mouth to the stomach. And it involves many, many muscles and nerves, and it happens just in a second. So you can imagine if there is something wrong, then it's something that really needs to be addressed because it happens so frequently, and it's something that's really tied to our overall health. And you might be wondering, first of all, why a speech therapist would be worrying about swallowing. And what I like to tell my patients is my scope of practice is everything from the neck up. So as a speech language pathologist, yes, I do work on speech. However, I also work with patients on swallowing. I work with them on voice, language, memory, cognition, all of those things to help rehabilitate my patients. So swallowing is definitely a big part of our scope of practice, and especially with the head and neck cancer population. So when we think about the swallowing, we divide it into three phases: the oral phase, which is number one there down in the corner, where the food or liquid is in the mouth; the pharyngeal phase, where the food or liquid comes down into the throat; and then the last phase is esophageal, which is when the food or liquid goes down into the esophagus. That would be a normal swallow and what we are hoping for. So when we are looking at the swallow, a lot of times we will describe which phases are impaired. So it's good to know what those are. A big part of our scope of practice is working with patients with head and neck cancer. Again, head and neck cancer is identified by the primary site of origin of the malignancy. So that can be anything from the nasal cavity to the oral cavity to the pharynx or larynx, kind of the throat area, and the salivary glands. Globally, head and neck cancer accounts for approximately 880 thousand to 1.1 million new cases of cancer annually. And in the United States, 3.6% of all cancers are head neck, with approximately 65,000 Americans developing head neck malignancies annually. So this is a pretty large population, and we're excited to have some treatment tools and ways that we can serve these patients to help them come through their treatment better. And really, head neck cancer is a changing landscape. So traditionally, head neck cancer was seen in older individuals, primarily in their 60s and 70s. It was heavily male. Usually patients had a history of tobacco use or alcohol consumption. Now, the human papillomavirus, or HPV, is a major factor in oropharyngeal cancer. And this is really important because tumors that are HPV positive or are coming from that residual HPV virus have different genetic presentations. They behave differently during treatment. Typically, patients who are whose tumors are HPV positive are finding their cancer younger. So they're maybe, instead of 60s and 70s, they're 40s and 50s. A lot of these patients are non-smokers, and a lot of times they don't know that they have the cancer until the tumor is quite large. However, this type of cancer, of head neck cancer, HPV positive, does have a very good treatment outlook, a good prognosis. It responds really, really well to radiation treatment. Patients whose tumors are not HPV related usually have to undergo surgery and a combination of chemotherapy and radiation. So it just requires a little bit more intervention to work with those tumors. And, it's important to note that about 85% of individuals will get the HPV infection in their lifetime. Obviously, not all of those patients get cancer. So this is something that they are studying very heavily. And really, they are promoting the HPV vaccine. There are 3 available right now, starting at age 9 and primarily from age 9 to 12. And there are 2 doses, but it can be given all the way up into adulthood. It's just something that you have to talk to your doctor about. So we have a way to fight this, but it is something that is kind of evolving. So we have to keep that in mind. And when we think about head and neck cancer, certainly dysphagia and difficulty swallowing is a big risk factor of a treatment toxicity that we're going to see. So the prevalence of dysphagia ranges from about 40 to 60% of patients. Some studies go up to 65 or 75% of patients. So it's a good amount of the patients undergoing treatment. And dysphagia can occur before treatment, during, and after. And so it's very important to get involved and get that evaluation done and make sure that we're setting you on the right path. Because dysphagia can ultimately lead to other complications such as malnutrition, pneumonia, and poor quality of life. Eating and drinking is such a social activity, and it is so tied to our quality of life that when patients can no longer do that in the same way, they really take a hit. And so we try to help preserve and protect their swallow as much as we can. And obviously, the factors that are going to determine whether dysphagia is present are things like where the tumor is located and how large it is, what treatments the patient is getting. Some patients have surgery that takes away some of the anatomy, so we have to learn how to use what we have left. Other treatments like radiation and chemotherapy can damage tissues and nerves. So combination of those, we might have to investigate ways that we can help. The radiation dose, obviously a higher dose is going to lead to increased difficulty with swallowing. Other factors included increased age, female, and a combination of chemotherapy and radiation, especially kind of at that throat level. So we call it the middle pharyngeal constrictor muscle. And so if that's kind of in the line of treatment, a lot of patients do have more dysphagia in those cases. So again, if someone's not able to swallow effectively and safely, we could be looking at malnutrition. We can be looking at aspiration pneumonia if things go down the wrong way. And we're going to look at kind of what that looks like here in just a little bit. Reduced quality of life and psychosocial distress. If a patient has to be hospitalized because they're not able to get the adequate nutrition and hydration, we look at increased lengths of stay for hospitalization and weight loss. Other complications that can come from treatment, and we're going to talk more about those later as well, are things like dry mouth and painful swallowing. So certainly those will impact a person's comfort level when they're swallowing as well. So how can we evaluate this? How can we get ahead of it? Main thing is that we want to be involved right from the start, ideally before the patient starts their chemotherapy or radiation treatment. And I'm going to talk specifically about dysphagia and swallowing right now. Primarily, we do have a role as well in the head and neck cancer population for voice and cognition, but usually those treatments come later as the patient needs them, whereas swallowing, we really like to get involved as soon as possible, and we're going to talk about why. So the American Speech and Hearing Association identifies the speech pathologist scope of practice as a central role in the screening, assessment, diagnosis, and treatment of people with head and neck cancer. The professional roles and activities in speech-language pathology include clinical education and educational services, such as diagnosis, assessment, planning, and treatment, prevention and advocacy, and education, administration, and research. And really, our role is to support our patients all the way from diagnosis through treatment and survivorship. I've been honored to be part of patients' journeys all along the way, and really enjoy working with this population because we can have such an impact on their quality of life and getting them back to doing what they want to do. So typically our first meeting for our patients is going to be a swallow evaluation, and really this is just used to establish a baseline. What are we working with now? Are we already experiencing some dysphagia? Sometimes yes. Again, depending upon where the tumor is located, patients may already be having some difficulty swallowing. That might have even been their first indication that something was wrong. Some patients, on the other hand, have no difficulty swallowing, but we still want to get involved because we can anticipate that that's going to be a problem down the road, depending on what treatment they're getting. So what we're going to do is we're going to gather a detailed history. We're going to talk with the patient and sometimes their family if they're present. We complete an oral motor exam, which is where we look at all the muscles in the mouth and the tongue, and we kind of look at the neck and the range of motion and just really see what we're working with, as well as the cranial nerves that help to coordinate and control the swallow. We then give trials of different consistencies of solids and liquids. And we do this just to kind of see, are there any outward signs or symptoms of something that is going wrong? Is there some, rehab exercises or strategies that we can recommend right away? And a lot of times we can. And in general, we're going to go through, there are exercises that the patient can start even before they begin radiation. And research shows that those patients do better all the way through treatment if they've already started with those exercises. A lot of times I tell my patients, I wish I had X-ray vision, but I don't. And so to make sure that we are getting the full picture of what is going on with the swallow, we might need to proceed with what we call an instrumental evaluation. And I'm going to talk about the two instrumental evaluations that we do here at North Kansas City Hospital. And those are just very helpful as far as treatment planning And again, kind of having a record of the baseline of what the swallow function is before the patient even begins their cancer treatment. So the first one is going to be what we call a video fluoroscopic swallow study. You might also hear this called modified barium swallow study or VFSS. This instrumental assessment uses fluoroscopy, and the patient is seen in radiology with both a radiologist and a speech language pathologist. And what we do is we give the patient solids and liquids that are coated or made up of barium. And the barium shows up on the x-ray, and we can actually watch the swallow and where the food and liquid goes in real time as it goes down. So we are able to assess the full swallow physiology and function, and we can determine if there is aspiration or food or liquid going down the wrong way. We can identify why, where that's happening, and which muscles we need to target in therapy to help make that better. We can also diagnose silent aspiration, which we can't see when we're just looking with our naked eye. A lot of times, patients have food or liquid go down the wrong way and they don't have any outward signs or symptoms that it's happening. So no coughing, no choking, no changes in their voice. And so really this is the only way to see if that's happening. And so again, we can visualize the muscle, the structure, we can gather information for diet, we can test different strategies and see what's going to work really well for the patient. So for example, if I have a patient who has maybe tonsillar cancer and it's on the right side, we might see if maybe doing a head turn to the left can help push the food and liquid past the tumor if it's impeding the swallow. So we can really do a lot of different things to help compensate and get you set up for the most comfortable eating and drinking as possible. And so these are just some pictures of kind of what that looks like. So the speech pathologist is usually standing in front of the patient. So that gentleman with the blue lead on would be the speech pathologist. And we are giving the patient instructions, giving them the food and liquid to eat while watching the screens there to see what's going on. And the patient's usually sitting in the chair and just looking straight ahead. And so that picture on the right is the view that we see. So you can see the mouth and the throat, and that black kind of area is the barium. So it does show up black on the screen, and we can follow it again all the way down. So I'm going to show you on the next screen a little video of what we see. So the first, it goes pretty fast, but the first video shows what a normal swallow looks like in a video swallow study, where the food and liquid goes down the esophagus into the stomach. The second is an abnormal swallow where the person aspirates and the food or liquid goes down into their trachea or their airway. So we can watch that together. So nice, smooth swallow, it all goes down. You can see some of it's falling down, and oh, there's some of it going down the esophagus, but you can see right in the front that it also went down, unfortunately, into the airway. So it can give us a lot of good information. Now, not everyone needs a video swallow study, and there is another instrumental swallow exam that we offer that it does not involve any exposure to radiation, and that is called the fiber optic endoscopic evaluation of swallow, and that's also can be shortened to FEES. And in FEES, a speech language pathologist passes a thin, flexible instrument through the nose. You can see that down there in the corner. It's just got a teeny tiny little camera and light at the end. And we get a different view of the swallow. We can see what the tissues look like. Obviously, when it's an x-ray, we can't really see the actual tissue, whether it's red or swollen. And so this really does give us a different aspect of the swallow. We can look at the safety and efficiency of the swallow. We can look to see if there's penetration or aspiration, or like I said, things going down the airway. We can look to see if the swallow is delayed, if the patient has a lot of residue after the swallow, maybe they're not getting everything down. And we can also look again at structural abnormalities of the vocal cords and larynx that we don't get on the other view. And so for this test, generally a patient is given regular food and liquid. They don't have to have barium, but it is dyed. Usually we use a green food coloring, so it shows up really prominently on the screen against our pink, throat tissue. And this can be done over the course of a meal, again, because a patient doesn't have to be under fluoroscopy. There's no exposure to radiation. And so let me show you kind of what that looks like. So before I start, you'll see that the opening there's two white little areas around that opening. Those are the vocal cords. And then this flapper kind of down at the bottom is the epiglottis. So we have that view from the top, and we can look down as the person is eating or drinking and see, where that food and liquid is going. Again, if someone has some kind of tumor, it would also be visible on this view, so we could really see how it's impacting the swallow. So I'm going to get this started, and we'll kind of jump ahead. So she's going to take a little drink, and it happens very fast. But her throat closes, the liquid goes down the esophagus. Okay, so obviously that study is very helpful. It does take a trained eye to be able to watch that and determine exactly what's going on, because it does happen so quickly. But we have a lot of very skilled speech pathologists here that are able to do that, and just very happy to be able to offer that to our patients. Moving into treatment, so we've seen the patient, we've identified if there's any dysphagia happening, and we've kind of given them some baseline strategies or diet modifications or education that they need to kind of get going. And so what does treatment look like? So in general, when we're thinking about head and neck cancer, treatment differs depending on the location and the stage of the cancer, as well as the general health considerations of the patient. So most of our patients will have a combination of these three therapies. So surgery might be used to remove the tumor and surrounding tissue. It might also be used to remove some affected lymph nodes if the cancer has spread. Reconstructive surgery may be used to rebuild areas where the tissue has been removed. So that also kind of comes with its own set of complications, because now we're dealing with structure and anatomy that is not innervated in the same way that it used to be, and it may not have the same movement or function that it used to. Chemotherapy are drugs that kill the cancer cells, and for head and neck cancer, it's often used in combination with radiation therapy, especially for patients that have more advanced cancers. Radiation is high energy rays that kill the cancer cells. And so if you look in that top right-hand corner, you'll see kind of an example of what a patient usually looks like as they're going through radiation. So most patients will have some kind of a mask or something to keep their head completely still, and then the radiation is targeted at the area of the tumor. And so radiation can be used in early stage cancers. It also can be used in conjunction with surgery and chemotherapy. Other options for treatments that I don't see as often with head and neck cancer, but they can be used, are things like targeted therapy, immunotherapy, and proton therapy. And I'm sure in the future as well, the field of cancer research is always expanding, and the options that are available to patients are also expanding. So I'm, very hopeful that in the future we'll even add to this list of ways that we can fight this cancer. And treatment for head and neck cancer really does involve a big multidisciplinary team of specialists all working collaboratively to move you in the right direction. So that team might include the surgeon, the radiation oncologist, the medical oncologist, usually an oncology nurse, and a social worker to kind of advocate and guide the patient through, a dietitian, a mental health therapist, physical therapist, and then of course, speech language pathologist. So I'm going to talk specifically about my role, but just know that this is a very collaborative effort, and patients, again, do very well when their treatment team is all on the same page and working together. So the first role of the speech language pathologist is education. So we want to make sure our patients have education on potential treatment-related side effects. We want to make sure that patients understand the typical course of treatment and recovery, what to expect. Research shows that when patients know what to expect, they wind up doing better with therapy and just in their treatment overall. We also want to make sure that they're aware of changes to watch for in their swallowing, like those signs of aspiration or things going down the wrong way. I think a lot of times, because we swallow so frequently and sometimes the dysphagia develops very gradually, patients may or may not be aware that they're having a problem at all. So giving them that education of things to watch out for, we can potentially prevent a hospitalization. If someone's having something go down the wrong way, obviously we don't want anything in our lungs that's not air. And when we have other things, that can lead to an infection and probably pneumonia and hospitalization. So if we can catch it early and the patient is aware of what to watch out for, then we can hopefully prevent them from having to go into the hospital. Going to those potential treatment-related side effects, a lot of times we call those treatment toxicities. This is just a short list of the most common ones that we deal with, and again, that are most impactful for the swallow. So the first one, the highest prevalence there, is dry mouth. So we help to alleviate this with many different things. First of all, there are several over-the-counter medications that can help, such as Biotin. There are prescription strength mouth moisturizers that can also be used. And again, actually, doing the exercises has been shown to help with dry mouth and taste sensation, which is the next treatment toxicity there, also known as dysphagia. 90% of patients do report changes in their taste. Thankfully, this usually returns back to normal pretty fast after radiation is done. Dry mouth, on the other hand, can persist for quite a while. Most of my patients say that when they have the changes in taste, everything either tastes really bland or really metallic. So a lot of times we'll talk about just strategies for avoiding foods that are super high in iron or really bitter, maybe switching over to plastic utensils instead of metal, and just different ways that you can capitalize on maybe the taste sensations that are preserved, and avoid those foods that are going to just not taste as good. Weight loss, malnutrition, again, that usually is a result of the first two. If it's not comfortable to eat or it doesn't taste good, most of the time patients aren't going to want to eat. Also, we know chemotherapy can make patients a little nauseous. And so again, I really encourage patients to talk to their doctor about any treatment toxicities they're experiencing. And there's a lot of, medications out there that can be prescribed to help alleviate some of those symptoms. I tell them nobody gets an award at the end of treatment if you didn't take any medicine. So you might as well use it and make sure that you're taking care of yourself and you're getting adequate nutrition, because you need all of the strength and energy that you can to help fight the cancer. A lot of patients have chewing and eating difficulties. Sometimes patients will get stiffness in their jaw, which can make chewing difficult, or depending on what surgery they had, they might have had all of their teeth extracted, and that will make chewing obviously very difficult. So we talk about modifications and ways they can make food a little bit softer, but still palatable. Mucositis is like kind of sores in the mouth, irritations. Again, there's things that we can do for that. Magic mouthwash is kind of a numbing agent that can be used. As we talked about before, dysphagia or difficulty swallowing, 65% of patients. And then some of those lower numbers are less common toxicities. But again, not everyone will get all of these toxicities, but we just like to talk about it to make sure people are prepared and they know kind of what to look out for. And if they do wind up developing some of these, we work through them together. And again, all of that starts with prophylactic treatment. So before the cancer treatment even begins, we need to talk about strategies to help manage some of those treatment toxicities. We do swallow exercises to help maintain range of motion, strength, coordination of the swallow musculature. And we provide that education to help the patient plan and prepare for the future. So just some little snippets of the outcome of this prophylactic treatment. So patients who started their swallow exercise program before their chemotherapy or radiation reported improved saliva production, smell, and taste. So if you remember from the last slide, those were two of the big, really top treatment toxicities. So if we can help alleviate those, then I would say that's a big win. Patients were able to maintain their weight. They reported improved swallowing-related quality of life, and they were 25% less likely to miss radiation sessions. Maybe, some patients are not able to stick to their radiation schedule because they need to be, they need to get IV fluids because they're not getting enough hydration, or they need to go to the hospital. So 25% less likely to miss those sessions, stay on track, and get through their treatment in the fastest way they can. So just a few other little, snippets here. When speech language pathologists intervene prior to the initiation of cancer treatment, patients are able to resume oral diets and eliminate feeding tubes 11 days sooner than those seen after the start of cancer treatment. We have seen decreased costs, so decreased healthcare costs, less hospital readmissions, less complications, and less mortality. We also see an increase in knowledge, preparedness, and treatment adherence. So 80 to 90% of individuals undergoing a total laryngectomy reported improved knowledge and preparedness for surgery, and they were 13 times more likely to adhere to treatment recommendations. So again, just really, really helpful to get started early and get on the right track and have that support so you know what to expect and try to get ahead of some of those treatment toxicities. So typically during the cancer treatment phase, where the patient is maybe undergoing radiation, chemotherapy, or a combination of both, the speech language pathologist meets with the patient in our practice every other week, as long as the treatment toxicities are pretty well managed. So we understand that our patients are busy, that they have a lot of doctor's appointments, and really we just try to cater all of our treatment to meet the patient's needs. So it's not a typical therapy in the sense that you're coming multiple times a week and it's really intense. This is really just checking in and making sure that we're staying on track. We can increase to weekly treatments if the toxicities are getting worse and the patient needs more support. So really, when we think about it during treatment, I think about our role as more of preservation. So trying to preserve and protect the swallow as much as we possibly can. And then after treatment, our goal changes to restoration, getting the patient back and rehabilitation back to where they want to be. And this can be swallow, this can be voice, and this can be cognition as well. So during the treatment, usually we will do the oral exam. We'll see how is everything looking. We'll measure jaw opening to make sure that that is being maintained. We'll review those exercises, and then we'll give the patient some things to eat and drink just to check on that swallow function and make sure everything looks good. And then a big portion of the treatment session is dedicated to education and problem solving. So individual complaints of the patient of what's been going on or what's been bothering them or questions that they have. We spend a lot of time talking about that so that they feel heard and can get all of their questions answered. And if there is something that's very concerning, again, we have that team approach. So we'll reach out to the appropriate team member to make sure that the patient gets what they need. So our role for swallowing rehab, again, we teach strategies. So if there's something that the patient can do to make their swallow safer, maybe it's turning their head, maybe it's taking a smaller sip, maybe it is, some kind of positioning depending on what they need. We talk about diet textures and modifications, again, how they might need to change their eating and drinking, or the preparation of the foods to make it either more comfortable or safer throughout treatment. A lot of times this involves making foods a little bit softer and maybe a little more bland for a while. We also have a role in lymphedema management. So as those lymph nodes are impacted by the chemotherapy and radiation, a lot of times they don't move the lymph fluid through the body as effectively, and that can lead to swelling. And obviously, if there's swelling in the neck or throat regions, that can impact swallow. So we kind of partner hand in hand with our occupational and physical therapy friends to really work on that lymphedema and make sure that swallow function is maintained. And again, if we see that the patient's having trouble with something like nutrition, we can refer them to the dietitian. If we see that they're having trouble with fatigue, we can refer them to physical therapy. So whatever they need, we can reach out to that discipline. The exercise program, again, each exercise is kind of tailored to what the patient needs. However, in general, most patients, we will recommend a course of stretching, and there's different, there's different tools that can help with that. We also, one of those being the Aura Stretch Press, which is mentioned there. It's a kind of a stretching tool that opens up the mouth. We talk about breath support. EMST stands for Expiratory Muscle Strength Trainer. And so if you have things that are going the wrong way, a lot of times it's important to have that cough strength, that expiratory muscle strength to help get it out. Patients that have used the EMST device have been shown to have fewer hospitalizations. And even if they have dysphagia, they've had fewer instances of respiratory infection. We always talk about tongue range of motion. We have a little device called the tonguometer that we can use to help exercise the tongue. And then we can use a vital stim machine to provide biofeedback so the patient can actually see what their muscles are doing. And it's a really awesome way that we can measure from session to session how those muscles are changing and getting stronger. So again, we just have a lot of research that shows the benefits of therapy. And I just wanted to highlight those. So doing swallowing rehab can help decrease feeding tube dependency. Sometimes if patients are unable to meet their nutrition or hydration needs by mouth, then they do require a feeding tube during treatment. That's what we want to avoid. So 32 to 90% less likely to require a feeding tube. That's a pretty big range, but we do know that patients were much less likely to have feeding tubes following 3 to 6 months following cancer treatment, and they had their feeding tubes removed 12 to 16 weeks sooner if they did have to get one. Patients were 4 times more likely to improve their swallowing function, 36% more likely to achieve a functional swallow, 3 to 4 times more likely to eat a solid diet, and 4 times more likely to maintain improvements in their oral diet over time. So again, the benefits of therapy also are not just during the cancer treatment, it will really help serve the patient for years to come. As it relates to voice, our role, we can work on things like vocal hygiene. We can work on resonant voicing, which will help with hoarseness or breathiness. A lot of our patients do have to have laryngectomy, so we can help patients using a laryngeal speech or electrolarynx. And if our patients have to have a tracheostomy, we can help with using the passing ear speaking valve to help them get that voicing. So it's really amazing. You know, I've had patients before that have had some of these surgeries and they're like, you know, there are ways that you use your voice that you never think about. You know, they said, well, I can't go through a drive-through anymore. I can't talk to a teleprompter or a telephone prompter anymore. And it's very exciting to be able to give people their voice back and just help them, be able to do those things that maybe we often take for granted. In the realm of cognition and communication, we know that chemotherapy in particular can cause certain changes in cognition. Potentially, patients a lot of times refer to it as chemo fog or brain fog. So we really use cognitive strategy training to help compensate for that. Also, some patients, particularly if they are, if they have brain cancer, maybe we're dealing with some surgical changes as well. And we really look at the concept of neuroplasticity. The brain is an amazing, amazing thing. And when one part of the brain is damaged or not working well, other parts are able to kind of take over or reroute that information, and we can get that function back, which is awesome. And so we really capitalize on this in our therapy to help, rehab patients and get them feeling back to where they were before. We do cognitive exercises to practice some of those strategies, and the exercises might work on anything that the patient feels like they're struggling with, and that can include things like attention, memory, problem solving, and language. So I want to talk a little bit about survivorship, because a lot of times, we have this idea in our head of, okay, I'm going to do 35 radiation treatments and then I'm done. And unfortunately, a lot of times with this kind of treatment, the effects of the cancer treatment may not stop as soon as the radiation is over. And so, like I said, once the treatment is done for the cancer, our job really is to kind of step it up a notch and really kick the rehab portion into high gear to get patients back to where they want to be. So the survivorship for patients with stage 1 or 2 head and neck cancer is 70 to 90%, so very high. And as the survival rate improves, it's very important to address post-treatment concerns appropriately and critically important to our patients' quality of life. Again, just because the radiation is over, it doesn't mean that the effects of what it is going to do are done. So a lot of times, like I said, that dry mouth will persist. A lot of patients will continue to have dysphagia. A lot of patients will continue to require a feeding tube, depending upon, again, how severe their treatment toxicities were. And that lymphedema that I talked about earlier, radiation fibrosis, which is kind of making, which is the muscles get kind of stiff, can all impact the swallow function for years to come. So what we really want to do is set our patients up for success so that they don't have to come back to us in 5 years or 10 years because these treatment issues have persisted. We also want to really support prevention and early recognition to help reduce the overall burden of this disease on patients. So there were new recommendations set out in 2022, and those included improving general access to care. I think one of the silver linings of the COVID pandemic was to, maybe increase the use of teletherapy, and that allowed a lot of people who maybe were in rural areas to have access to care that they wouldn't normally have access to. So just a little bit of a silver lining, and I think that hopefully that'll continue to expand and just give people access. We want to definitely do tobacco and alcohol cessation counseling. Research shows that 50% of patients who are smoking at time of diagnosis continue to smoke after diagnosis, and obviously that leads to poorer prognosis and patient outcomes. I talked earlier about the HPV vaccination in teens and young adults, and that's just a way that we can prevent these individuals from even getting the virus that could potentially cause head and neck cancer down the road. Education to support patient and clinician recognition of earlier cancer, regular screenings for body image disturbance, distress, depression, and anxiety, and again, things that are going to help just support the whole person. The cancer might be, in the tonsil, but we really have to address the entire person, and that includes, physical health, it includes emotional health, cognitive health, all of those things. And so we want to do that to make sure our patients have the best outcomes. So even after treatment, as I was saying before, the effects of radiation, including scarring and fibrosis, can build over time and reduce the ability of the throat muscles to function properly. So when I give my patients their exercises, my recommendation is they probably need to keep up with them at least a couple times a week, indefinitely. And the National Institute of Health found that new dysphagia-related diagnoses continue to occur at clinical meaningful levels in long-term head and neck survivors beyond 5 years. So that's, just showing that it's something that's going to stick with the patient. And as long as they stay up with their exercises and stay mindful of their swallow, then, they can do really well. But it's something that they're going to have to continue to think about even when their treatment is over. And the recommendations for regular follow-up with the healthcare team to monitor for any new or worsening swallowing problems. So we will typically work with the patient after their chemotherapy or radiation is over for several months or weeks, depending upon what they need. After we discharge them from therapy, they have our information. They can call us at any time. I really encourage patients to reach out and keep me updated on how things are going, but also encouraging them to maintain their regular health screenings and talk with their doctor if anything new or different comes up, or they have any remaining questions. So just some takeaways. HPV has emerged as a significant factor in the rise of oropharyngeal cancer, which has changed the epidemiology, treatment, and prognosis. Dysphagia from cancer treatment can significantly impact a patient's quality of life, which makes eating and drinking difficult. Speech-language pathologists play a central role in the screening, assessment, diagnosis, and treatment of people with head and neck cancer, and prophylactic treatment is associated with better outcomes. 50 to 60% of survivors continued to have dysphagia beyond 5 years, and so ongoing speech pathology involvement is important. So we want to help maintain those relationships and keep our patients on the right track. So with that, I would love to open it up if anyone has any questions.
I have taken our attendees off of mute. If anybody wants to come off mute or utilize the chat, that would be great for your questions. While you guys are going to put your thoughts together, first and foremost, Stephanie, you are an absolute wealth of knowledge, and your ability to just communicate all of these really complicated things so simply is refreshing. So thank you so much for all that information. I will tell you, speech therapy is one of my favorite skill sets. My sister was diagnosed with ALS, and she's since passed away, but our speech therapists were by far the most talented and caring and empathetic and just absolutely the best. So my heart is open to you guys and the work that you do for sure.
Oh,
So
that's
we'll
wonderful.
wait for a couple questions, but I do want to share we've got some other great opportunities to learn, especially if you are in the oncology service line care. We've got July 23rd, Dr. Fagman is going to be talking about lung cancer screenings. And all the Wednesdays in May, we're going to be at the Gladstone Community Center doing skin cancer screenings from 11:30 to 1:30, if you want to join us there. And on June 12th, we've got a great session hosted by Gilda's Club titled Making Treatment Decisions, as well as some great programs. Again, we've got Stephanie in July talking about chemo brain and then navigating that oncology journey. A panel of young adults is going to be coming in August 14th. So lots of programming to come support you in your cancer journey. And again, we've got a couple questions here. Let me look down in the question and answer. We've got a great information. Don't wait to get into therapy once diagnosed. I think that is a huge takeaway. When you talked about the exercises and preparing
Mhm.
and before things go wrong,
Yeah.
big, big boom in my head.
Yeah. And I think in my experience, their patients kind of come to me and are a little bit confused maybe. Because first they're like, well, why am I seeing a speech therapist? There's nothing wrong with my speech. And so then I have to kind of explain our role in swallowing. And then maybe they're not experiencing swallowing issues yet, which is
Mhm.
great because we can catch it early. But again, I kind of have to explain, this is why it's important to do that early. And then I would say most patients are super, super happy that they came in because they just feel so much more prepared and also supported. I mean, like it is a journey and you have so much information coming at you from so many different people. And I think just being able to kind of consolidate some of that information, provide some guidance and support, and just make sure people feel empowered as they just begin this battle is very important.
Yeah, absolutely. Well, thanks again, everybody, for joining us today. And I do want to take this opportunity, if you haven't heard the fantastic news, North Kansas City Hospital Meritas Health has joined with Mayo Clinic as an affiliate. And so we have all the expertise from the Mayo Clinic coming here as well to Kansas City. And so you won't have to travel up to Rochester, Minnesota for that care. And that's just absolutely exciting for us. So thank you, everybody, for joining, and we'll see you next time.